Welcome to the Evacuation Logistics course. The purpose of this training is to review the primary logistical considerations associated with the process of partial and full evacuation of the hospital and patients. The first section addresses resources-related issues, including staffing, supplies, and equipment needed to maintain continuity of care. The second section describes the process for preserving the integrity of the physical plant and considerations for post-evacuation recovery of the hospital. When an evacuation code is announced, all personnel on duty should remain on duty within the facility until released by competent authority. HR policies for Emergency Operations Plan activations regarding retaining staff and extending shifts should be followed. Depending upon the scale of the evacuation, the planning section chief may opt to recall off-duty staff to assist. The first staff recalled are those who most recently went off-duty. Instruct these members to report back to the hospital's labor pool for staff assignments. The second group recalled is staff due to report for the next shift. Depending on current conditions and personnel needs, contact and assign some employees to report to the receiving facility to where patients are being evacuated. Personnel reassigned to assist at a receiving facility should wear their hospital identification cards per hospital policy and check in at the labor pool of the new location. If staff members are traveling with patient transports, notify the receiving facility's labor pool, sometimes called the personnel staging area, concerning their anticipated arrival. Ideally, address credentialing of these staff in a pre-existing memoranda of understanding or mutual aid agreement between the facilities. Best practice systems establish such agreements across the community, encompassing all of the facilities and providers in case of the need for one or more facilities to evacuate. If not pre-planned, do this in compliance with the receiving facility's medical staff emergency credentialing policy and direction from the hospital command center. Staff must report to the receiving facility's labor pool, show appropriate identification, sign in, and await assignment. Make every attempt to relocate needed staff to a new or altered work location. Private transport may be taken to a new location, except where law enforcement advises or circumstances dictate that travel is impractical or unsafe. No staff member should relocate to any other facility without being formally requested and having established positive accountability and specific direction from a competent authority. Maintaining continuity of care during an evacuation is vital, regardless of conditions. There are 3 elements necessary to maintain care: clinical staff, equipment and supplies, and an appropriate or improvised environment of care. Augment and reschedule clinical staff as needed to meet the evacuation needs and support clinical care objectives. Typical assignments of staff from unaffected units are made to help establish and maintain the patient holding areas and patient loading areas, and to provide clinical accompaniment for patients where indicated. The personnel tracking manager under the planning section chief, along with the labor pool and credentialing unit leader in the logistics section, are responsible for identifying and coordinating these assets. These personnel are then positioned, as needed, at the direction of the evacuation branch director or the operations section chief, if the assets are going to be used in support of activities not directly involved with the physical evacuation. Necessary equipment and supplies should be brought to patient holding areas from the units evacuating patients. As requested by the evacuation branch director, surge area supply carts may be provided by hospital materials management staff to support activities in the holding and loading areas. Additional or ongoing material needs should be requested from the logistics section based on the anticipated length of stay of patients in the 2 areas. Items needed may include oxygen, biomedical equipment such as cardiac monitors, portable suction units, infusion pumps and ventilators, and general medical supplies. In addition, linens, privacy screens, portable lighting, and infection control supplies may also be required. Some of these supplies may also be requested at the receiving facility. In this circumstance, The logistics section coordinates these needs with the receiving medical facilities. Careful documentation is essential to expedite cost recovery following the evacuation. In the event of a total evacuation to an off-site location, 72 hours of medication should ideally accompany the patients. In many facilities, the inpatient areas have no more than a 24-hour supply of pharmaceuticals in the medication cart or automated medication management system, such as Pyxis. Place these medications in a zippered reclosable bag with a patient identity label affixed. In the event it is determined that more medications are needed than are available on the unit, the pharmacy should run an additional medication fill list. Place these additional medications in a zippered, reclosable bag with a patient identity label affixed, and send to the unit to accompany each patient to their new location. Should time not permit the additional medications to be packaged and matched up with evacuating patients before they depart, then the supply unit leader in the logistics section, in coordination with the clinical support unit leader in the operations section, ultimately ensures that the medications are packaged and delivered to the relocation sites in a timely manner for the patient's use. Only send essential controlled substances with the patient upon evacuation, like lorazepam for an uncontrolled seizure patient. If the patients are being sent to another healthcare facility with an inpatient pharmacy, only provide the medications needed while in transit to this facility. The clinical support unit leader should communicate with the other facility to determine if an inter-hospital transfer of medications is required. If the patients are being transferred to a facility that does not have a pharmacy available, first determine what medications are essential, and then how much medication to send. Fill these medications from the pharmacy and place them in a zippered, reclosable bag with a patient name label. Place these bags in a securable container and lock for transport. Under any of these circumstances, a pharmacy-controlled substance receipt should be filled out and must accompany the medications. Keep in mind that the pharmacy and any pharmaceutical supplies left behind when evacuating the facility need to be secured. Establish pre-plans for securing medications stored on units and safeguarding the pharmacy stock. Pay particular attention to maintaining environmental controls where indicated and maintaining a chain of custody for controlled substances. Anticipated and ongoing needs for medical and non-medical care equipment, supplies, and pharmaceuticals are managed by the logistics section in coordination with the hospital's materials management staff. The primary responsibility of materials management during an evacuation is to identify supply and medical needs with local vendors. Warehouse materials should be staged for transport where practical and if time permits. The logistics section, in coordination with the receiving medical facilities, should also determine materials in need at the receiving medical facility or alternate stopover locations. Careful documentation will be essential to expedite cost recovery following the evacuation. Subject to medical capability and space availability, the hospital may serve as a receiving medical facility and accept a transferring medical facility's patients in the event of an emergency evacuation. When notified of an evacuation emergency by another facility, the hospital should provide capacity and capability to accept evacuated patients from the transferring medical facility. As requested through the regional bed capacity identification process, this information should be provided within 30 minutes. The data reported shall include both licensed and surge or overbedding capacity. The following presents a typical set of agreed-upon evacuation terms and responsibilities between facilities. Clearly, such agreements are best identified and agreed to prior to an emergency. The receiving medical facility provides medically necessary healthcare services as required by patients transported to their facility. These services are provided at the receiving medical facility's then prevailing rates. Each of the medical facilities follows their standard procedures for admission, protocols for providing care, and procedures for discharging patients. The transferring medical facility is not obligated to pay any charges imposed by the receiving medical facility unless such liability would exist separate and apart from this agreement. The receiving medical facility collects such charges from the patient or the patient's third-party payer. The transferring medical facility is responsible for arranging transportation of evacuated patients to and from the receiving medical facility. The transferring medical facility pays the transportation cost and seeks reimbursement by billing the patient or third-party payers. The transferring medical facility will provide the receiving medical facility with as much advance notice and information as possible regarding any patients requiring evacuation. As conditions warrant, the receiving medical facility activates their emergency operations plan and surge plan. If the receiving medical facility does not have the medical capability and available space, it may decline to accept any or all patients. Additional agreed-upon terms are: at the time of the transfer, the transferring medical facility sends consent forms and any identifying administrative, medical, and related information that may be necessary for the proper care of the transferred patients to the receiving medical facility. At the request of the receiving medical facility, the transferring medical facility makes clinical and/or ancillary staff available to maintain continuity of care for the transferred patients at the receiving medical facility's location. Such staff may accompany the patients during transport, or other arrangements may be made between the facilities. The transferring medical facility sends with each patient at the time of transfer, or soon after, medications, patient records, medical administration records, specialized treatment supplies, and the patient's personal effects. In the event that personal effects cannot be sent with an alert and competent patient, the transferring medical facility may elect to secure such personal effects until the crisis is over. The transferring medical facility will remain responsible for such items until the receiving medical facility acknowledges receipt of them in writing. As conditions evolve during an evacuation, give consideration to relocating several incident facilities. An alternate hospital command center, as well as a public information area and labor pool area, should be established at the receiving facility that is closest to the transferring hospital. This relocation will expedite both the evacuation and the recovery, or repatriation process, by enabling the command and control element to remain operational without interruption. When the nature or cause of an evacuation dictates that a hospital building or campus is to be left unoccupied for 24 hours or more, the physical plant must be shut down and secured in an orderly manner. Securing the building is vital to maintaining the security, integrity, and mechanical functions of the physical plant. This includes managing the control of medical gases, natural gas, boilers, generators, heating and air conditioning plants, telecommunications and data systems, electrical power, and water. Such activities are the responsibility of the Infrastructure Branch Director from the Operations Section. At the direction of the incident commander, take the following steps to perform a shutdown and secure all utilities. The facility's engineering department dispatches mechanics to stand by at medical gas and vacuum systems and await instructions if a campus-wide shutdown is in order. If a partial shutdown is required, a mechanic is sent to the affected area to await instructions from the Infrastructure Branch Director. Building management system technicians should stand by at their computers to perform an emergency shutdown of HVAC systems and domestic water systems. Assign mechanics to the oxygen farm to stand by for orders to shut down main feeder valves for the central oxygen system. If a partial shutdown is required, the mechanic assigned to shut down local medical gas systems will perform the oxygen shutdown. The plant engineer should stand by for instructions to possibly shut down chilled water systems and boilers. If the need arises for a partial electrical shutdown, the electrical foreman should assign electrical staff to stand by at key panels and await instructions. If a full campus shutdown of the electrical systems is necessary, notify the local electrical utility to perform this process. The hospital electrician should stand by to disable the backup generators. As utilities are secured, the mechanic or technician securing them must follow all necessary lockout or tagout procedures and report the final disposition to the infrastructure branch director. Perform the shutdown of utilities as the final steps in an evacuation, only when initiated by the order of the incident commander. Once the incident commander deems it is clear to perform a safe and orchestrated shutdown of the utilities, the sequence of shutdown should be coordinated with the infrastructure branch director, who will direct the actions of the appropriate unit leaders, mechanics, or technicians standing by to perform the shutdown. Depending upon the circumstances, a stay team may be left behind to secure and safeguard the facility and manage the physical plant shutdown as needed. The stay team, typically led by a manager within the logistics section, consists of security, engineering, and environmental services staff. The number of team members is based on the work to be done and the risk assessment for the stay team. For example, if evacuating due to an impending storm, the team will be minimal and focus on securing the facility. If the evacuation is secondary to a fire now extinguished, the team size may be significant and focused on recovery, restoration, and cleanup activities. From the moment that an evacuation has been deemed necessary, leadership planning should initiate recovery and reoccupancy planning. Once the cause of an evacuation is resolved, the HICS organization can then apply full focus and energies to a timely reoccupancy. Reoccupying the medical facility typically follows the reverse sequence of the evacuation. Clearly, the major difference is the pace of events and the associated urgency. The process begins with assigning authority to someone on site to determine if and when reoccupancy can occur. The facility or evacuated area must be inspected to ensure the area is safe for return. Reoccupancy is enhanced if a facility recovery team is staffed appropriately and their responsibilities defined. Together, these individuals determine the criteria for reoccupancy and the order of repairs required. Protocols and checklists for inspection of the physical plant support systems must be followed. These systems include fire and life safety systems, security, power, water, and HVAC. In addition, generators, chillers, elevators, telecommunications, data, mechanical, and utility systems must be inspected. Finally, environmental factors such as air quality, presence of mold, or contamination by hazardous materials must be determined. Completion of these steps influences the decision-making process concerning when patients can safely return to the facility and the timing and sequencing of the reoccupancy. In addition to inspection and repair activities, reoccupancy requires a process for determining that sufficient materials and supplies are available and supply lines are intact. As the reoccupancy process progresses, staff needs to be kept informed of the progress and when they can expect a return to duty. In this course, we have presented the service and support elements of an evacuation, including deployment of staff, resource and equipment needs, receiving facility guidelines, shutdown of the physical plant, functions of the stay team, and recovery and repatriation of the facility. Forms will be used in the patient loading areas to verify onward destinations and mode of transport. Remember that all of today's technological systems originated with paper systems, so any of them can readily fall back to paper-tracked systems if technology is not available. Most patients' personal property, other than prosthesis or assistive devices, will not be transported during a brief evacuation. It will be left behind, safeguarded by the hospital, and returned to the patient once the hospital is reopened. Hospital plans should specify the process to track the arrival of each patient at their predetermined ultimate destination. They should also specify the plan for patient repatriation to the original facility when the hospital returns to operational status. The tracking form used should contain key patient information, such as their medical record number or identifier, indication as to whether or not the original chart was sent with the patient, the time the patient left the facility, and the name of the transporting provider. In addition, the form should include a list of medications sent with the patient, whether or not the family has been notified of the transfer, and their contact information. As conditions evolve during an evacuation, give consideration to relocating several incident facilities. Establish an alternate hospital command center, as well as a public information area and labor pool area at the receiving facility that is closest to the transferring hospital. This will expedite the evacuation, recovery, and repatriation processes by enabling the command and control element to remain operational without interruption. In this course, we have presented the role, focus, and functions of incident management in the process of hospital evacuation, and continued with the functions of incident communications, staff mobilization, and patient tracking. In the final training course, logistical considerations specific to hospital evacuation will be presented.